This is the first of 2 episodes of the GenoCare podcast with Associate Professor Amy Nisselle. In this episode, we explore the role of education in supporting both patients and clinicians as genomics moves into routine healthcare. In the next episode, we'll shift focus to what it actually takes to embed genomics into healthcare systems and what needs to change to make that work in practice. We all know that change in healthcare can be challenging. And so one of the key issues is how do we adopt these genomic technologies so that people can benefit from those changes? Access to these technologies can be a challenge, and there are a wonderful bunch of people across Australia who are working on this issue and looking at how and what we do to approach improving access to genomic technologies. And so that's why I've invited Associate Professor Amy Nisselle today to join me on this episode of the podcast. So Amy provides genomics education research, development and evaluation expertise. She works for a number of different organisations, including Murdoch Children's Research Institute, the University of Melbourne and the University of Queensland, and has previously held roles at Australian Genomics and Melbourne Genomics. Thank you so much, Amy, for joining us today, and welcome to the GenoCare podcast.
Thanks, Ali. It's lovely to be here. Thanks for inviting me on.
Can you tell us a little bit about your work and how you've come to focus on this area? Because it is a very specialised and interesting area, but also perhaps there might not be much awareness about people like you who do this type of work. So just giving our listeners a little bit of background about how you came to do this and what it is that you do.
Sure. So you're right. When I was at school, no one said to me, you can be a genomics education expert when you're a grown-up. I always thought I was going to be a scientist, and I am still a scientist, but I don't work in a lab. And it took me a while to realize that you can still be a scientist and not work in a lab. So when I was about in my late 20s, early 30s, I answered an ad to work at what is now VCGS, Victorian Clinical Genetics Services, because they wanted someone to come along who had a genetics background, but was also a project manager. And at some point between my undergrad degree and then, I had picked up project management. And I thought, how on earth are my two things coming together like that in an ad? And what it turned out to be was my first step into the amazing, wonderful world of genetics and research and health and screening. So to put all those words together, I ran a project which looked at what the Australian public thought about being offered a simple, easy genetic test in the workplace for a common condition. So it was a real forerunner of acceptability and feasibility of population screening programs. So it was the early 2000s, and it was led by two absolutely amazing people, Professor Martin Delaticchi and Professor Katie Allen. And they wanted to look at how you could prevent a really common disease called hemochromatosis. And it's a very simple genetic test. It's a cheek swab, and 1 in 250 odd Australians have a copy of the gene. And if you have 2 copies, you're at risk of hemochromatosis, which is an iron overload disorder that's really easily preventable by giving blood. So I knew none of that before I took the job, but I very quickly learnt it. And what it boiled down to for me was, how do you explain genetics in a way that allows people that have stepped away from their desk or the production line or the footy field in 20 minutes and give them enough information to make an informed decision about whether to have a test or not. And so that opened the door to me to this place that I really love where I work, genomics or genetics education for different audiences. It's really about science communication. It's about how do you describe something super complex so someone can make an informed decision. And when you pare it down that much, it really allows me to say that I do that for either doctors, clinicians, scientists, patients, the general public, children, whole range of different people. When I give a tute to university students, I always start with a picture. And I say, imagine there's a woman who's presenting to her GP and she thinks she might have a lump in her breast. And the doctor assesses the woman and thinks that she might need to go off and have this checked out. And she mentions that she had an auntie that had breast cancer. So she thinks, right, the GP thinks I better send her off to genetics because there might be something in the family here. She goes off and sees a genetic counsellor who arranges a test. And sure enough, it comes back that she has the BRCA1 mutation. So the geneticist and the breast surgeon and the genetic counsellor recommended prophylactic mastectomy, which she goes ahead and has. And she gets seen by a social worker while she's in her recovery and physiotherapist, OTs. And the genetic counsellor follows up with her and makes sure she's understanding what all her options are. And also that would she like help explaining this to her family? And so the woman goes away with some brochures and some tools in her toolkit to help explain this to her family. And then those family members then go and see their GP. And so when I present this story, every single person in that story has to have some sort of education to understand what to look out for, how to react, how to do their role, and what comes later. And so that's my piece of the puzzle. So I help all of those people. So it might be the woman through a campaign that she saw on the telly to say breast lumps need investigation. So she went to a GP. The GP needed to know to ask the questions that the woman then said, oh, yes, my auntie had this. The GP then needed to know how to refer. The counsellor obviously got all their training through their genetic counselling course. The breast surgeon may or may not have specialised in this area. The social worker is a very fleeting part in this puzzle, but she also needs to have an understanding of it. The OT and the physio, they need understanding. And then someone had to make that brochure that the patient took home and gave to her family. So that's my world, helping people understand and be able to do what they need to do in the genomics era. Bit of a long answer, but that's what I do and that's what I love.
A long answer, but makes so much sense. And thank you for taking me right back to the work that you did with hemochromatosis, because it's reminded me that is actually how I got to know you, because I remember you coming to teach in the what was then the graduate diploma of genetic counselling course. And you were teaching about and sharing your experience of being part of that study. And I remember being really inspired by what that work was doing. And in terms of, and it just got me thinking really creatively about getting genomics out into the community. And I've always been really interested in that. And I've ended up working in a number of different screening programs. And I always often think back to having that sort of inspiration that you shared right back then, because I think that was probably one of the contributing factors that got me really interested in screening.
Unreal.
Yeah, which is really cool. But I think what you've really touched on just in describing what you do is something that I also observe, which I find quite interesting, and I guess I've found this over the years too in developing content for the screening programs that I've been part of. And you've also helped me in some of those situations. So I've been super grateful to tap into your expertise. But there's an art to it, to distilling really complex information into really simple terms, but then turning that into brochures or videos or website content or fact sheets or whatever that is. And I've noticed over the years that often people who work in this space just have a go at it themselves, but actually in order to do it well, you really need some deep expertise. And so I've always been grateful that I've had that knowledge, because I haven't, and I've been able to tap into knowledge from people like you, because I haven't then had to go through all the hiccups that can happen when you try and create something without that real deep expertise on how people make sense of and digest this type of information.
Yeah, it's a fascinating point. So I've been in this space now for over 20 years, and I always feel really humble that it's not rocket science. A lot of what we do is intuitive. But then, as you said, actually what I don't know if you've read The Hitchhiker's Guide to the Galaxy, but it's a Babel fish. So I'm one of those people that sits between two disciplines and I translate one to the other. And you're right. I skipped over the bit in the middle when I went off and did my PhD about this topic. So after I was doing that original hemochromatosis work and I became really interested in how do you describe genetics, I went off and I had the opportunity to do my PhD in that area and then did my postdoc overseas in the same area. And I got the chance to sit for 3 or 4 years and immerse myself in all the education theory, all the evaluation theory. And there is a really amazing wealth of information about how you learn science, how you can help people understand that there's concepts. And it was really funny when I was studying my PhD, I suddenly realized why I was such a bad science student at university, because I can't go beyond the visible. So when you're teaching science, in the background, there's describing things you can see, there's describing things you can see with the microscope, describing things that you can't see with the microscope, but you can create experiments to visualize them. And then there's symbolic. So it's macro, micro, meso, symbolic. And once you understand that, it does become an art form in terms of you don't lump a lot of things in together where you suddenly realize you're asking the reader or the learner to jump between all those levels and do mental arithmetic and jump over hurdles just to understand a concept. So that's why if you think back to school, or if any of the listeners are thinking about any brochure they've seen, they generally start with a cell and then they go to a nucleus and then they go to a chromosome and then they talk about the twisted ladder all bundled up in the chromosome and you unwind it to try and read it. And when you pick it apart further, there's molecules and we give them letters. And if you think about what I just said, we've gone from the visible to the visible under a microscope to the microscopic and then the symbolic. We've given them letters, A, T, C, and G. So you do this thing where you just make sure that you're giving concepts in an order that builds on the previous one. And even before you've done that, you've got some rigor in there and that you've gone and sense checked who needs to know this. So a huge part of my work over the last 10 years was doing what's called needs assessments, finding out where is the Australian population at? Where are the doctors at? Where are the genetic counsellors at? Where is the public at? Where are the students at? Where are they now? Where do they want to be? And how would they like to learn to get there? And so before we do anything in my work, we always do that sense check. We might think we know what people want to know, but do they actually want to know it or need to know it? And what role would they have? I'll get to it a bit later in the conversation, but one of the papers that took us a long time to nut out was what can Australian doctors do according to Medicare or according to the College of Physicians? What tests can they order? What tests can they order independently? What tests can they order in conjunction with a genetic service? And what tests they always just have to refer. And one of the ways you can think about it is like a CAT scan or an X-ray or a brain surgery. So back in the day, CAT scans and MRIs and X-rays were introduced. And it would have been ridiculous to think that a GP could order a patient to go off and have an MRI. But what still happens is the GP can order it, but the GP doesn't interpret it. The radiologist does that and gives a report. And we're on that same cusp now with genomics. There's a technology that we know is super useful, but who has the time, the inclination, the skills, and the understanding to order it? And who has the time, skills, understanding to interpret it and then act on it? And so that's where, again, some of the art of the education comes in. When you're describing a package, an education package, what are you trying to achieve? Are you trying to get a paediatrician in rural Queensland to be able to order a genomic test and act on the outcome for their patient? Probably. Are you wanting them to be able to go into a lab and understand exactly what it is that the laboratory scientists do to get that result? Maybe not. Probably not. There might be a couple that want to know that level of detail, but doing that helps you create education that's really fit for purpose. And so that's the key part to it, is understanding the needs of your audience, be they an interested public or a family or a doctor or a counsellor, and what you're going to do to meet that need. And then thinking about feasibility. So that rural paediatrician in Queensland probably can't attend a university course that's every Thursday afternoon for a month. They could probably attend a workshop at a paediatrics conference if they get a locum to fill their spot while they're away. And they can certainly do an online course if they've got the time. So you also think about the practicalities as well, what you're designing and how accessible it is to your target audience.
So I think that's one really key takeaway message from this already is before you even want to create any content, you need to actually stop and think, why are we doing this?
Yep.
Who's it for? How are they going to engage with it? And that process, whilst it might feel like you're slowing the whole thing down because everyone's really busy and they've got lots of competing priorities and they just want to get on with creating a brochure or whatever it is, a piece of content. But actually stopping and mapping it out allows you to be much more strategic about how you produce it, and then it has a much higher likelihood of having the impact that's desired.
Absolutely. And I'd add two things to that. One is that there's an approach you can use called a logic model, which is, like you said, mapping it out. Part of the work we did when I was working with Australian Genomics was create a whole bunch of tools for people to use if they ever wanted to create education to help them think like this. What we found back about 10 years ago now was that the majority of programs and resources that were being made in Australia, as you said, were being made by very well-meaning people who were clinicians or scientists or patient advocates who had a gut feeling that some education was needed and were creating it and doing the best they could with their funding, with their time, but they typically didn't have any training in education or evaluation. So we made all these tools to try and help them that are on the Australian Genomics website for the moment. And it's about, the very first one is that logic. Just a few things to think about when you're designing education, which literally does start with what's the goal? What do I try to achieve here? Who are the main stakeholders? Who should I be thinking of when I'm doing this? And then working backwards from the goal. What's the outcome I want? How do I achieve that in the long term? Before that, what's the action that's required to lead to that? And if I was to make some education, what would lead to that? And if I'm going to make the education, what do I need to do that? And really importantly, part of that was to do an opportunity analysis. What's already out there that I might be able to leverage? You don't always have to reinvent the wheel. So that's one of the things. And I was trying to remember the other thing you said then that pinged for me about mapping the landscape. Oh, that was it. And the other thing that seems counterintuitive, and it does slow you down, is to think, how am I going to show impact or measure success of my thing? So when you're planning, and it might be a brochure, how do you know that your brochure's worked? So is there a way you can think at the very beginning of the planning how you're going to evaluate that? Is it going to be a simple count of how many brochures got picked up from various GP waiting rooms? Is it going to be a QR code you've got on there for a website? How many more hits you got? Is it going to be how many people went and spoke to their GP about something? If so, how might you measure that? So it's a bit more of a challenge for your average person who's doing this as an add-on to their full-time job. But it is really important because you can then think of, why would you want to evaluate? Part of it is just to make sure that you're achieving what you wanted to achieve. But it might also be that you're starting small and you want to work up and you need to show that your proof of concept has worked. And you might be able to then apply to an advocacy body, or if you're a researcher, you might be applying for a grant to do this on a bigger scale, or do it for another condition. You might be thinking about some sort of screening program that's targeted specifically at these families that have a family history, but what if you wanted to target a different group? So evaluation can really help you show success, and you can leverage that again for the next phase of what you're trying to achieve.
There's just so much knowledge here. And I think, it really highlights that there are important people like you with these skill sets who can help organizations, services actually hone in on what it is they're trying to achieve, and then come up with a strategy for how to do it and how to do it effectively. If we zoom out and think, because education really becomes like an intervention for incorporating genomics into, and we use this phrase in genomics, mainstreaming genomics, which can sound quite abstract, and particularly to people who aren't as familiar with this industry. What does that look like in terms of day-to-day care for clinicians and patients? Like, what do we mean when we're talking about mainstreaming genomics? And I guess just to take a step back, we're at this point where we're on the cusp of genomics becoming part of everyday healthcare. So what are we trying to achieve in this concept of mainstreaming genomics, and how does the education piece fit into it?
Yeah, sure. I'll pick up on a couple of analogies I used before. So a GP ordering a genomic test, it might be NIPT for a pregnant couple, it might be carrier screening for a couple that aren't yet pregnant. They are what we call a mainstream doctor. So mainstream is anything outside genetics services. Again, going back to the concept of brain surgery, I always like, when I'm thinking about an argument, going to the absolute extremes and then working your way back into the middle to try and help understand what it means. We would never try and we would never try and mainstream brain surgery, because we would never expect a GP or a different type of doctor to be able to perform brain surgery. It's super highly technical, multiple years and decades of training to be able to do that. what we're trying to do when we talk about mainstreaming genomics is take the parts of genomic medicine that are understandable and can fit into a 15, 20-minute consultation, so practical, and that the skills can be learned by other doctors relatively easily to then be able to offer genomic medicine far more broadly. So the need for mainstreaming is because the genetic services don't have enough staff and facilities to keep up with the need for the test. So you need to start thinking about who else can we be enabling to do that. So that's what mainstreaming means. And it doesn't just mean GPs, it means anyone who has the capacity in a health system to recognize a patient who would benefit from a genetic or a genomic test, and then have access to be able to arrange that test for that patient. And this is where mainstream is a global term, but the interpretation of what it means on the ground is different depending on your local healthcare system. And local health systems differ across Australia, in every state and globally. So, for example, in the States, genetic counsellors can order some genetic tests. In Australia, a genetic counsellor cannot currently order any type of test. In the States, a physician's assistant is somewhere between a nurse and a doctor, and they can order some tests, but we don't have that role here. Same with a nurse practitioner. And then in different countries across Asia and Africa and Europe, there's also lots of different models in South America. So what mainstreaming means is broadening who can arrange genomic testing for their patient. So on a spectrum, that can range from, I don't want to do this myself, I don't have the time, or I find it a bit bamboozling, but I know who's going to benefit and I'm going to refer them to genetics, through to, I know my patient needs this and I'm happy to arrange it, but I'm not sure of the finer details, so I'll do it with support from my local genetics department, through to, I've got this, I want to order it myself, I'm in charge of the whole process. At the moment in Australia, there are some Medicare item numbers that mean that some types of specialists can order genomic tests directly. For example, a paediatrician with a patient under the age of 11 who's got developmental delay and has already had a couple of basic genetic tests, but they still need to do that after a telephone consult with genetics. That's part of the item number. Others, in say nephrologists in renal, kidney disorders, cardiology, oncology, they've got a bit more leeway, a few more item numbers. So it's changing rapidly. So even every 6 months or so, a new item number comes out for something. And that's largely in Australia in response to the efforts of a lot of clinical researchers. So Australian Genomics, Melbourne Genomics, Queensland Genomics, all sorts of organisations, state and national, have been working in this space for 10 to 15 years, trying to gather the data that the government needs to review whether a test should be Medicare rebatable or not. The next part about mainstreaming, I always like to think I did a lot of this work with my colleague at the time, Belinda McLaren, who I think you've had on your podcast as well. And it took us a really long time to conceptualize who the workforce was. But eventually we came up with this really nifty diagram for ourselves to help plan all our work. If you think about the people who use genomic testing, which are usually clinicians, and the people who conduct genomic testing, they're typically the scientists. So you've got the clinician who orders a test and the scientist in the lab who runs the analysis and produces the test result, which goes back to the clinician. So the people who use it and the people who do it. And then within each of those, it's like the target symbol. There's a bullseye in the middle, which is the people who have genetic training, the genetic specialists. So that might be a clinical geneticist as a doctor, a genetic counsellor as a clinician, or a variant curator, a medical scientist who has training specifically in analysing genomic data. They're the three, and a genetic pathologist who straddles them both. They're the four professions who are the bee's knees in this space. They're the ones that know every part of this, but there's not enough of them. So the next wave out on both sides of that diagram, you've got other clinicians. They might be a doctor, a social worker, some sort of counsellor, or a nurse. On the scientific side, you've got a truckload of other medical scientists who don't specialise in this space. What you've also got is another wave of people in the background, all of the data people who make all the systems that the scientists use. So you've got bioinformaticians, data scientists, software programmers, all those people. So a lot of these people outside that core bit wouldn't consider themselves a genetic specialist. They'd be like, I'm a nurse, I'm a software developer, I'm a physiotherapist, I'm a cardiologist. So the trick with the mainstreaming then is to bring the genetics out to them. And so again, when you're thinking about this from an education perspective, you instantly recognize the need is different. Therefore, the content of the education I'm going to provide will be different and the mode of delivery will be different as well. As I mentioned, a geneticist in training would 100% spend every Thursday afternoon in a clinic for years getting their training. A genetic counsellor would spend 2 years at university getting their training, but the cardiologist or the software developer probably won't. They would possibly do what's called workplace learning. They would learn on the job. So they would just get a job that happened to have some genetics or genomics exposure and learn from their peers. And what we know is for anyone, that is the gold way of learning. So if you can provide people with some foundational understanding, and that might be through an online course or through a one-day workshop or some resources, if they can get exposure in the workplace from a learned colleague, what we call a peer expert, then they're able to move along a continuum towards mastery of genomics. And that's what helps with mainstreaming. I'm throwing a lot of terms in here. You can tell that I love my literature and my little frameworks. I keep peppering the conversation with them. One of the really fun papers that we worked on years ago was asking Australian doctors who weren't trained in genetics, how ready are you? What do you think about genomics? Do you think it's relevant to your practice? Have you done any education? Would you like to do some? What sort of topics of mode of delivery? And what we found was that if you'd had a little bit of education, you actually dropped your confidence. And so I'll come back to this a bit later when we're talking about some really on the ground strategies. But what we found was that if you wanted to move along the continuum of complete novice across to master, you needed to get across a little dip first, that a little knowledge makes you nervous. Unless you're one of those superpowered people that thinks they can do everything and they don't care if they learn a little bit about something and they realize they don't know.
Yeah.
Which is dangerous in the healthcare world.
Yes, it is.
Yeah. And the last thing I wanted to say about the mainstreaming was different sectors, I would say, have different professions, traditionally the profession has different experience in getting ready for this. And funnily enough, the one that has been, in my experience, has been the best is nurses. So they formed the Global Genomics Nursing Alliance more than 20 years ago. So the nurses have been the front runners in getting ready to practice genomics. There's often what people cite as about a 17-year lag of technology bench to bedside. Sometimes other people refer to it as diffusion of innovation. And you can typically go through a whole heap of hurdles to get something really cool. And when you look at the timelines, it's fascinating because the genome was sequenced in 2000. It was around 2017 that the cost of genomic sequencing came down enough that it was started to be offered. So we're following the same 17-year rule in genomics. And so one of the things when you think about mainstreaming is we had to wait. It couldn't happen earlier because there were a lot of practical barriers in the way. The time it took for the testing and the cost it took. And also there's a whole bunch of organisational issues here around whether a health system or a hospital literally has the practical capabilities to incorporate ordering a genomic test. These days, most systems run electronic medical records and they are still working to be able to get a genomics plugin to handle the data and the transfer and along with privacy and confidentiality. There's all sorts of governance issues there. So there's a few things that play with mainstreaming, but the overarching concept is how do we unplug the bottleneck? I think I mixed my metaphors, but how do we stop that bottleneck happening where everyone's waiting for an appointment with genetics?
Yes. And that is absolutely what we're still seeing today across genetic healthcare in Australia is
it's
big
similar
bottleneck.
to genetic.
Big bottlenecks. And that is actually what we're trying to help with GenoCare. And I'll come to that in a little bit more detail a bit later when we talk about digital tools. I think that 17-year lag is so interesting because as you're talking about it, I was thinking my area that I've been working in for my career has been reproductive genetics or genomics. And when I think about 2017, that was right around the time where NIPT had come in and was becoming quite well established at that point. So it came in around 2013, 2014, but by 2017, People were more familiar with it. The labs had done a decent volume of testing. The systems were starting to get more bedded down. And that was also around the time that expanded carrier screening was also starting to get established. So in reproductive genetics, that fits perfectly. It's fascinating.